Hello, this is Dr. A with a clinical chemistry review on the assessment of acid-base imbalances. So, acid-base balance, there are two independent variables. There's the respiratory mechanism and the renal mechanism. So, the respiratory mechanism will regulate the partial pressure of CO2, and the renal mechanisms, the kidneys, will regulate the bicarbonate concentration. So then you can evaluate acid-base imbalances by starting by looking at the pH. So if you have acidosis or acidemia or too much acid in the body, the blood pH is going to be below the reference range or below 7.35. But the acidosis could be metabolic or respiratory. And I'm going to show you how to assess that here in a minute. Or you could have alkalosis or alkalemia or too much base in the body if the pH is greater than 7.45, and again, it can be metabolic or respiratory. The metabolic disorders usually involve the bicarb concentration, and the respiratory disorders involve the carbon dioxide concentration. So once you've assessed the pH, you got to go look at these other components to see what's going on. So let's start with the first one, the metabolic or also known as non-respiratory acidosis. It's generally caused by a bicarbonate deficit, so the bicarb is low, there's not enough bicarb. And there are two types. There's the elevated anion gap acidosis and the normal anion gap acidosis. In the elevated anion gap acidosis, the bicarb is consumed through the buffering of excess hydrogen ions. So there's a lot of acids that are being produced in the body. Some examples are diabetic ketoacidosis, where keto acids are produced, lactic acidosis, where lactic acids are produced, the ingestion of methanol or ethylene glycol, and renal failure uremia. All of those lead to accumulation of acids in the blood. Or in a normal anion gap acidosis, this is due to the loss of the bicarb from the body, either through the kidneys or through the GI tract. Diarrhea is a common cause. Another cause will be renal tubular acidosis, where bicarb is lost in the urine and not reabsorbed by the kidneys. So we can have either excess of acids or loss of bicarb and get a metabolic or non-respiratory acidosis. The body compensates for these in several ways. So usually metabolic disorders are compensated by respiratory actions. So in metabolic acidosis, the respiratory action is to hyperventilate. And if you think about it, just think of CO2 as an acid, and so it's trying to hyperventilate so it can blow off all the excess acid as CO2. The kidneys will also compensate by trying to excrete this excess of hydrogen ions and try to increase the reabsorption of bicarb, but the renal mechanisms are really slow. They can take several days to really work. So on your ABGs, your lab findings are going to be, because we're in acidosis, going to be a pH of less than 7.35 or below reference range. You will see either a normal or a decreased pCO2 because of the hyperventilation. And you will always see a low bicarb levels because the bicarbs are, if it's the one with the excess acids, they're used up trying to buffer the excess acids, or they were lost. All right, so next we have alkalosis, metabolic or non-respiratory alkalosis. So this one is, again, because we're metabolic, it's going to be bicarb. Problem is this time is a bicarb excess. So how do you get too much bicarb? One of the ways is to, if you have an increased ingestion of bases, so if somebody's taken a bunch of antacids, or they were given large infusions of bases through IVs with high, IVs with high bicarb content, or numerous blood transfusions. It can be due to a decreased excretion of bases, so diuretics can cause this condition by blocking electrolyte reabsorption and increasing the excretion of the hydrogen ions. So you're losing, if you will, too much acids there through your kidneys. Or high levels of aldosterone in Cushing disease also can lead to an increased excretion of the hydrogen ions. So basically you're losing too much of the acids. Or you can have a loss of acidic fluids. It's like your GI, from your GI tract, but we're thinking of the acidic fluid in the stomach, so from prolonged vomiting. Patients with cystic fibrosis will have an impaired ability to produce hydrogen ions, and that could also lead to alkalosis. The compensatory mechanisms for metabolic alkalosis are the respiratory system is going to attempt to compensate, and so it will do so instead of hyperventilating. In a way, we're going to hypoventilate, so it's going to breathe slowly and deeply in an effort to increase the amount of carbon dioxide. So again, if you think about carbon dioxide as an acid and we're too alkaline, then we can increase the amount of acids to balance things out. So because carbon dioxide is converted to carbonic acid, and carbonic acid reduces the pH. The kidneys will try to excrete the excess bicarb, of course, but again, their actions tends to be a little slower. Your lab findings on your ABG report can be a pH above reference range or above 7.45. Normal or potentially elevated CO2 level and an elevated bicarb level. So everything's moving in one direction. So both for, if you notice, for the metabolic acidosis and alkalosis, your abnormal values all move in the same direction. So for alkalosis, everything's up. For acidosis, everything's down. Now let's move to respiratory. So respiratory acidosis is due to alveolar hypoventilation. So you have an excess of PCO2 accumulating in the blood because it can't leave the body through adequately, at least through the lungs. So what happens is carbon dioxide removal by the lung is slower than the buildup in the tissues. You have acute and chronic respiratory acidosis. So in acute respiratory acidosis, the respiratory center is depressed by the ingestion of drugs, especially if you're taking a lot of downers and pain meds and stuff like that. Could be due to head trauma or central nervous system brain trauma or an infection. Or it can be due to conditions such as asthma or other airway obstruction if they were strangled or have something that was lodged in the windpipe and stuff. So that all will cause acute respiratory acidosis. Chronic respiratory acidosis can come from comatose states because they have a depressed respiratory system, or from COPD, chronic obstructive pulmonary disease, and that's organ involvement, the organ being the lungs, and in COPD, which is emphysema and chronic bronchitis, etc. You have a loss of surface area in the lungs, and so there's not adequate surface area for the removal of all the CO2 that's being produced. The compensatory mechanisms are metabolic because since the problems with the lungs is you can't compensate with the lungs. So initially the buffer systems will elevate the bicarb levels, but only slightly. The renal compensation will occur, but it'll take 2 to 3 days and will result in an increased excretion of carbonic acid, an increased reabsorption of bicarb, and an increased sodium reabsorption in exchange for the hydrogen ions. Again, respiratory compensation is not possible in all patients because usually there's problems with the lungs and stuff. The lab findings on the ABG, so if your patient has acute respiratory acidosis, the pH will be low, below reference range, but his PCO2 will be high. So the values are moving opposite directions there, and the bicarb is generally normal. In your chronic cases, the pH will be normal or maybe slightly low because when you're in chronic cases, the body is compensating for it long term. And their PCO2 will be chronically elevated because they just cannot remove all that CO2, so it just stays high pretty constantly. But your bicarb is going to be elevated, so the body, that's the way the body compensates in chronic cases, is it simply raises the amount of bicarb so it can neutralize this excess acid. And that's how the pH is normal. And then lastly, we have respiratory alkalosis. So this is due to alveolar hyperventilation. When you hyperventilate, you lose too much PCO2. And so that leads to a decreased partial pressure of arterial carbon dioxide, and that decrease in CO2 will decrease the ratio of bicarbonate concentration to the PCO2, which then will increase the pH level. There are a variety of causes, anxiety, excessive crying, and like panic attacks, so like emotional upset and stuff like that where people are hyperventilating, but also drugs, septicemia, cerebrovascular accidents such as strokes and stuff, and it is also a common finding in patients that are on mechanical ventilators, and that would be basically they were maybe in respiratory acidosis and they put them on a ventilator and they kind of overcompensated and went into respiratory alkalosis. So they were breathing too much for them. And then usually what happens is they will modify the ventilator settings to just kind of back it off the breathing and get back to normal. The compensatory mechanisms for respiratory alkalosis are the opposite of respiratory acidosis. So the cellular buffer systems will release hydrogen ions to lower the pH, and the kidneys will excrete more bicarb. And in the lab findings, your pH is going to be elevated above reference, so above 7.45, and the CO2, the PCO2 is going to be decreased. So again, they move in opposite directions, and the bicarb will be normal. And I do like this chart. So if you start with an arterial blood sample, if your pH is low, you're in acidosis. If your pH is high, you're in alkalosis. And then if the component that's out of whack is the bicarb, so if the bicarb is low, you're in metabolic acidosis. If the CO2 is what's out of whack and it's high, you're in respiratory acidosis. And then if you're in metabolic acidosis and your PCO2 is less than 40, you have respiratory compensation going on, and there will be a 1.2 millimeter of mercury decrease in PCO2 for every per 1 milliequivalent decrease in bicarb. And so here, if you're in respiratory acidosis with a high PCO2, if the bicarb is above 24, then you have renal compensation, and there will be a 3.5 milliequivalent rise in bicarb for every increase of 10 millimeter of mercury in PCO2. So here on the other side on alkalosis, then high pH, again, you look if the bicarb component is out of whack, but it's high, you have metabolic alkalosis. And if the CO2 component is low, then you have respiratory alkalosis. And then for metabolic, if the PCO2 is greater than 40, that means you had respiratory compensation with a 0.7 millimeter mercury increase in PCO2 per 1 milliequivalent increase in bicarb. And if you were here in respiratory alkalosis with the hyperventilation and stuff, if the bicarb is less than 24, then you had renal compensation happening, and there's a 5 milliequivalent decrease in bicarb per 10 millimeter of mercury decrease in PCO2. And that is it. Thank you for your attention.